Good afternoon, everyone. This is exciting. This is going to be a fun session here. I'm Benji Matthews from Health Partners Minnesota and on the annual conference committee. Going with tradition here, the course director for the following year does this introduction. For HM20, I filled the bill for that, so I got the call from the bullpen. You got Carrie and Chris who will be giving the talk here. Carrie Hertzke is a hospitalist at Johns Hopkins Hospital, where she serves in a number of leadership roles, including associate CMO. Her areas of academic focus include partnering with difficult patients and faculty development. Carrie went to med school at the Medical College of Virginia and completed her med-peds training at Duke before joining the medicine and pediatrics faculty at Johns Hopkins. Also found out if she was an Olympic athlete of some sort, she would choose swimming. Yeah. Chris Moriades is a hospitalist at Dell Medical School and at the University of Austin, where he's assistant dean for healthcare value and an associate chair for quality, safety, and value. I think he likes the word value. That's the key here. Through a number of initiatives, he teaches and engages clinicians in improving healthcare value for patients. He co-wrote the book, Understanding Value-Based Healthcare, and he's a co-chair for the International Choosing Wisely Medical Education Strategy. Chris went to medical school at the UC San Diego and completed his residency training at UCSF, where he joined the faculty there initially before moving to Austin. Please join me in welcoming Chris and Carrie.
Hello. Well, welcome. You know, Chris, before we start, do you remember when we found out we were going to be doing updates?
Absolutely. It was so exciting. We had never worked together. We were going to get to be on this big stage in front of so many of our friends. How cool.
We thought, we've got this.
Totally.
And then I spent the next several months in complete denial. And then you said, you know, we should probably look through some studies and prepare a talk. And so then I felt a little like this. But then we got to work.
That's right. We started sending each other just a few studies to look at in our spare time. Turns out there's a lot of research published in a year across many different topics. And as hospitalists, I guess we're responsible for knowing all of it. Yeah.
So we did what any self-respecting, sleep-deprived person would do. We drank a lot of coffee.
A lot.
A lot. And this got us wondering, is all this coffee good for us? Well, good news, there's a study for that published this year. So this study is to evaluate the association of coffee drinking with mortality and to see whether how you metabolize caffeine matters. It was a prospective cohort study using this huge UK biobank data set. And so it was over 500,000 participants. There's a lot of people in this database. And what they found was that coffee drinking is inversely proportionally and associated with mortality. So the more coffee you drink, the longer you live, including people that drink more than 8 cups of coffee a day. Wow, those people never leave the bathroom. And it doesn't really matter how you metabolize caffeine. And so the takeaway point is that coffee equals survival juice.
Oh, thank God, because I already have 5 cups of coffee today. I'm totally amped. I'm ready to go. We got 20 studies to review in the next 50 minutes. I'm ready. Are you guys ready? Should we do this? All right, come on, Carrie, come on. Bring the first case. Let's go.
All right, let's go. All right, our first case is a 55-year-old former CO with chronic pain due to a history of sternal crush injury who was admitted following opioid overdose.
Oh, man. Iron Man does not look happy after that naloxone. Let's talk about opiates for a minute. This shocking graph was published in the New York Times earlier this year, and it showed what unfortunately all of us are seeing in our communities and in our hospitals, and that's that deaths from opiate overdose have now surpassed other major epidemics of our time. So the deaths in 2017 are greater than peak HIV deaths in 1995, peak car crash deaths in 1972. Clearly, it's a public health crisis that we need to address. But what can we do about it? Well, this retrospective cohort study, published in Annals of Internal Medicine this past year, looked at the Massachusetts Public Health Dataset from 2012 to 2014. They reviewed nearly 18,000 opiate overdose survivors who either had an ambulance or hospital encounter. And shockingly, what they found was that of these folks who nearly died from opiate overdose, following them out for a whole year, only 3 in 10 of them received any medication for their opiate overdose, or for their opiate use disorder. Only 3 in 10 of this highest risk group over an entire year. And does it make a difference? It looks like it does. So mortality at 12 months was 4.7 deaths per 100 person years, but those treated with methadone or buprenorphine had significantly lower risk of death. Buprenorphine, also known as Suboxone, it can actually be prescribed by anybody in the hospital without any sort of extra training or waiver. You do need an FDA X waiver to prescribe it upon discharge or in the outpatient setting, but it's oftentimes much more accessible than methadone in many of our communities. Now, this is a retrospective study, so it's association, not causation, but this study suggests that the number needed to treat with buprenorphine to save a life, many of these young lives, is 50. Do you all know what the number needed to treat to save a life with aspirin and STEMI is? It's 42. And none of us act like that's optional. And in fact, earlier studies that have recently been captured in a systematic review suggest that buprenorphine may have a number needed to treat as low as 2 for keeping patients in recovery. So it seems to be high time that we take this on as a standard of care. During admission, Iron Man was found to have a fever, leukocytosis, and positive blood cultures. And I know what you're thinking, but it's going to be pretty hard to get an echo with that arc reactor in his chest. We asked the echo tech at Zuckerberg San Francisco General, and she said, "Don't worry, I've seen much weirder here." And indeed, she got beautiful pictures, and Iron Man has mitral valve endocarditis. Strap in, here we go. You're about to spend 6 weeks of inpatient IV antibiotics with Iron Man. I don't even know how you get an IV in Iron Man. Maybe not. The POET study, published this year in the New England Journal, is a randomized, non-inferiority, multi-center trial where they looked at 400 adults. It's worth noting they screened nearly 2,000 patients for inclusion. So already you know that this is not going to apply to all comers. These patients had left-sided endocarditis. They had a TEE that showed that there was no abscess, and they had been clinically stable after at least 10 days of IV antibiotics. At that point, they were randomized to either continue IV treatment or switch to oral antibiotic treatment. The primary outcome was a composite. They looked at all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia with the primary pathogen. This was from the time of randomization until 6 months after antibiotic treatment was completed. Looking at that composite primary outcome, those who continued on IV treatment, which has been our standard of care, 12% reached the primary outcome. Those switched to oral antibiotic treatment, 9%. This was a non-significant difference. After randomization, the IV treated group had received 19 additional days of inpatient treatment, whereas the orally treated group was discharged after a median of 3 days and received a total of 17 additional days of treatment. So we have more to say about this trial in a moment, but in this randomized trial, switching to oral antibiotics after at least 10 days of IV treatment was not inferior to continued IV antibiotics. And in fact, just last week at the American Cardiology Conference, the authors of this study presented follow-up data looking at 3 years out. And they published this as a correspondence in the New England Journal Online last week. And what they found was even following out 3 years, there seems to be no difference. No difference in mortality and no difference in recurrence of infection. So 2019 may be the end of an era for IV antibiotics, because in that same issue of New England Journal, right below it, in fact, was another study calling into question IV antibiotics for another indication that we've all been taught you must give 6 weeks of IV antibiotics, and that's bone and joint infections. The OVIVA trial, it's a randomized, multi-center, non-inferiority trial, and in this one, they looked at 1,000 adults, once again after screening more than 2,000 patients, so not all comers. And these adults have bone or joint infections. They were randomized within 7 days of surgery, or if they were being managed non-surgically, 7 days of starting antibiotics. They were once again randomized to continue IV treatment, as has been standard of care, or to switch to oral antibiotic treatment at that stage. The primary endpoint of the OVIVA trial was a definitive treatment failure within 1 year after randomization. In those patients who continued IV treatment, 14.6% had that primary endpoint of treatment failure at 1 year. And in those on oral antibiotics, 13.2%. Once again, a non-significant difference between the two groups. Couple more notes about this study. If you look at days since randomization, 77% of the patients in this trial were treated with antibiotics beyond 6 weeks, and sometimes well beyond 6 weeks. But importantly, there was no difference between those who were initially assigned to IV treatment and those assigned to oral treatment, which was important because the researchers had worried a little bit, since this was a non-blinded study, that perhaps the local physicians would just keep their oral antibiotic patients on antibiotics for much longer. But that did not happen here. So this was an inclusive study, no selection according to the infecting organism, the surgical procedure, or the anatomic site. And in fact, 61% of the patients in this study had metalware-related infections. So these were people with serious infections. There was no difference in serious adverse events. But we should note here that the oral antibiotic patients still had a 26% adverse event rate. So monitoring follow-up is critical, because if you're not checking in on them every day and writing a note and checking labs, you need to make sure that you're following these folks closely, because a significant percentage of them do indeed end up having adverse events. Catheter complications, of course, were higher in the group that maintained IV antibiotics versus those switched to oral. And hospital length of stay also was longer for those on IV antibiotics versus those switched to oral, 14 versus 11 days. Now, when our hospital administrators heard about these studies, they were stoked. Oral antibiotics for everybody, right? This is going to be amazing. We no longer have to have these patients sitting on our service for 6 weeks. Hold up, guys. A couple things we need to note. One, this is challenging a widely accepted standard of care. It might not be ready for a complete paradigm shift just based on single, albeit well-done, New England Journal studies. Also, as we mentioned, it is not applicable to all comers. They had to screen at least twice as many, and in the endocarditis trial, many more patients than they were able to enroll. And if you look closely at the methods of the POET trial, which the administration never looks closely at the methods, but you look closely at the methods, it says that oral antibiotic patients were seen in outpatient clinic 2 to 3 times per week. I do not know what world this happened in. I cannot get my patients seen in clinic 2 to 3 times per week. All of a sudden, the administration got a little less excited. So the takeaways, oral antibiotics are becoming the new IV antibiotics, only you don't have to stay in the hospital as long, don't have to spend as much time with Carrie and I. Patients still need initial IV therapy, and they need to be clinically stable before switching them to oral antibiotics. These are only single studies, so it's premature now to support widespread adoption, but it clearly sets a new platform for further studies, as long as we ensure the fact that these patients can be followed closely in the outpatient setting, much more closely than many of us can currently coordinate. You need the healthcare infrastructure for this close monitoring. And we also want to note that we need to remember many of these patients with endocarditis or joint infections have another underlying problem, and that's opioid use disorder. And if we just treat the infection without looking for and addressing the opioid use disorder, all we're doing is pumping up this tire, and we're not looking for the nail.
Well, speaking of nails, let's talk about someone who knows where all of your nails are, and your friends' friends. Mark Zuckerberg. He's had a rough year. After all those flights back and forth between California and DC to talk about privacy, he develops a DVT. And he admits between developing apps to share all of your secrets and then apologizing for doing such, he sometimes forgets to take his DOAC. So how is this going to affect your management of this DVT? Are you going to recommend warfarin? It was good for the last forever years. It's going to be good for years coming forward, right? How many people are going to recommend warfarin? No one? All right. How about apixaban? Eliquis means excellent, right? Who's going to do apixaban?
Come on, you can raise your hands, participate.
How about rivaroxaban? Even if you can't spell it, at least it's once a day. All right, so we got a little bit of a mix. All right, well, we'll get back to Mark. This has been a big year for DOACs. And so if you have patients with cancer, end-stage renal disease, or a tendency to live in the real world, which I'm not sure Mark does, then a DOAC might be for you. We're going to start with DOACs in the real world settings. This was a prospective open cohort study from 2011 to 2016 that included about 200,000 patients, just over half of whom were on anticoagulation for AFib. And of this group, as you can imagine, because this is when DOACs were still getting popular, 70% of patients were on warfarin. 4% were on dabigatran, 20% were on rivaroxaban, which seemed to be your favorite, and 9% were on apixaban. What they looked at was which drug did better. So they looked at how many bad things happened, so bleeding, and then they looked at how well it prevented the thing we're trying to prevent. So either DVT or VTE or stroke. And they also looked at mortality, because generally we like to avoid mortality. And you can see that the apixaban group really did the best. This actually included both the people in the low dose of apixaban and the high dose of apixaban. And when you look, the low dose of apixaban, so 2.5 milligrams, did much worse than the high dose. And so this actually underestimates how good apixaban was in this study. The researchers concluded that apixaban was the safest at higher doses, so 5 milligrams, had a lower risk of all bleeding and the best outcomes. Rivaroxaban and low-dose apixaban, concerningly, had a risk of all-cause mortality compared to warfarin. And when you look at the number needed to treat in this real-world study, the numbers needed to harm for rivaroxaban in both patients that have AFib and that do not have AFib was really low. So as low as 23 at 24 months. So pretty concerning for rivaroxaban. And this is consistent with other studies that have come out that have raised some concern about rivaroxaban this year. Moving from the real world to cancer, a real world I think many of us do not want to be. This is the edoxaban for VTE in patients with cancer study. This is one of a number of studies that have come out looking at cancer patients and DOACs. There's been one on rivaroxaban and a new one that's about to be published on apixaban. This was an industry-sponsored trial. It was multi-center and randomized, open label, and a non-inferiority trial. So just trying to see if these two drugs are equal. They put just about 1,000 people in this trial. Folks all had active cancer. Half of them had metastatic disease at admission or enrollment. And about 60% of these patients had PE as part of their VTE. And obviously, everyone had VTE. The groups were similar at baseline. And they randomized so that half got 5 days of dalteparin and then were transitioned to edoxaban, because edoxaban is one of those DOACs that you need to bridge. And the rest remained on dalteparin. On dalteparin. The primary endpoints were recurrent VTE or major bleeding. So when you look at recurrent VTE, the edoxaban did somewhat better than dalteparin in preventing recurrent VTE, so lower is better here. But when you look at major bleeding, the edoxaban is a little bit higher than dalteparin. And when you look closer, the people that bled in edoxaban, as well as the other DOACs, were people with GI cancer. And this has been pretty consistent in the DOAC literature in this population. What is notable is that patients who had major bleeding in the more severe type, like hypotension and death, were equal between the two groups, and this has also been pretty consistent. The mortality of the study was as high as 40%. However, it was not from bleeding or recurrent VTE largely, but because, if you remember, half of the patients had metastatic disease at enrollment, so most people died of progression of their disease. So the summary for this is that edoxaban, or really all the DOACs that they've looked at, or dalteparin or Lovenox, thumbs up in cancer. In patients with GI cancer, edoxaban, or again, rivaroxaban or apixaban, yes, maybe no. And so this probably just merits a conversation with patients, because they do likely have an increased risk of GI bleeding if they switch over to a DOAC versus stay on Lovenox. Often, though, patients in other studies have preferred to take a pill versus to be on the shot, even with this increased risk of bleeding. All right, so DOACs and cancer seem like a good combination. There are other combinations that are less good. Toothpaste and orange juice is the worst. There are some other combinations that we probably under-recognize how bad they are. So end-stage renal disease and warfarin is one of those combinations. There is studies showing that when we put patients who have end-stage renal disease and AFib on warfarin, we do not lower their stroke risk as much as we would hope, and they have much higher rates of bleeding, including intracranial bleeding, which, as you know, is quite unfortunate. So I, as well as many other people, were very excited to see this study in circulation of apixaban in patients with end-stage renal disease and AFib. As you can guess, this was a retrospective cohort study because no one at the time recommended putting patients with end-stage renal disease on apixaban. Therefore, most of the 25,000 patients were on warfarin. just over 2,300 patients were on apixaban. And as you can guess, there's probably something unique about these patients, but because it was a retrospective study, it's hard for us to know why providers chose apixaban. Apixaban is chosen of all the DOACs because it's about 27% renally metabolized versus other DOACs, which are somewhere between 30 and 80% renally clear. So apixaban does seem to make the most sense of the DOACs. In this group, even though the pamphlet insert was updated in 2014 to reflect that there should be no dose adjustment for apixaban in end-stage renal disease, over half the patients actually got the lower dose, which remember in the real-world study, the patients did less well. They were looking to see how well did this prevent stroke and how much did this lower bleeding risk. In Aristotle, which was the original apixaban trial, the risk of intracranial bleed was markedly reduced in patients on apixaban. Most patients in that study did not have renal disease, as you know, and so they were really hopeful that this study would show much lower rates of intracranial bleed, but they were the same as warfarin. What this study did show, however, was that all across bleeding, the risk of major bleeding was lower with apixaban than with warfarin in these patients with end-stage renal disease. And when they looked at the two doses, you can see here that on the side where most of the navy arrows are, it favors warfarin, and on the side here, it's favoring apixaban. This mustard color is the 5 milligram dosing, and the navy is the 2.5 milligram dosing. So again, it looks like 5 milligrams is the dose for this population as well. So I don't know about you, but when I saw the study, I was pretty excited. And Chris, I'm wondering if this is what your CEO should be excited about. It takes forever to bridge people with end-stage renal disease, or really anyone, on warfarin or on heparin in the hospital. If you're not ready to believe me, though, that apixaban may be the drug of choice, there are a number of other studies going on. So ADAXA and Renal AF are both looking at apixaban versus warfarin in patients with end-stage renal disease and AFib. And AVK Dial is looking at warfarin versus placebo to see whether these patients even benefit from anticoagulation. So this could be really, really life-changing for these patients. The takeaway from all the DOAC studies seems to be that if you are prescribing apixaban, thumbs up. And if you're not, like me, it may be time to think about making apixaban your drug of choice.
Okay, Carrie, I share your enthusiasm, but we do need to note here, apixaban is BID dosing, and it is challenging for many patients to take a pill twice a day. So when this really hits the real world, we'll have to see if the outcomes truly hold up, because the pill that gets in a patient's mouth is usually more effective than the one that doesn't. He's back. After 6 weeks of antibiotics, Iron Man's now back at the hospital with acute onset watery diarrhea, abdominal pain, fever, and leukocytosis.
He looks pretty ticked.
Well, yeah, do you know how hard it is to take that suit off a couple times a day? C. diff treatment. We've all had ingrained in us, Flagyl is first line for C. diff treatment. But looking into this, it turns out that the ID docs may have known for a while that that wasn't such a good idea. Here's Professor Robert Reed, who back in 2007, more than a decade ago, wrote an editorial about C. diff treatment. And he said, when it comes to C. diff treatment, you probably want vancomycin for your mother and metronidazole for your mother-in-law. Well, that's all about to change. Because the IDSA guidelines that came out this year had a number of important updates, and the one that we want to highlight is that oral vancomycin or fidaxomicin now should be used for initial treatment of even mild C. diff, even first time, rather than metronidazole, which was the previous guideline recommended first-line therapy. This is a strong recommendation based on high-quality evidence that essentially showed that the cure rates are higher for vancomycin and fidaxomicin than for metronidazole. Now, we don't usually feature guidelines at updates, but this is such an important one, I think, and both Carrie and I have continued to see Flagyl being used for mild C. diff in our hospitals. It is time to stop. Now the bottom line in 2019 is oral vancomycin for everyone, even your mother-in-law. And if any of you in San Diego treat my mother-in-law, I guess give her oral vanco as well. This is not going well. Although, the yellow gown does nicely match his helmet, which got us thinking, Carrie and I, about fashion and infection control. The AAMC put out this spread, where they said, we should actually dress more like this guy on the right without our white coats anymore. We should wear fleeces and short sleeves, no ties. I thought, that can't be right, can it? Are we supposed to look like that guy? So I turned to these finely dressed hospitalists, Chris Petrilli at NYU, Vineet Chopra in Michigan. I said, gentlemen, does anybody know what hospitalists are actually supposed to wear? Nobody's crazy enough to do a rigorous multi-center trial on attire, are they? And they said, of course we did. We studied what we wear. We're so evidence-based, even our clothes have a p-value. And indeed, they did. Petrilli, Chopra, Sanjay Saint, and colleagues actually performed a cross-sectional observational study across 10 US academic medical centers, where they surveyed more than 4,000 adult patients who were receiving care in clinics or who were admitted to the hospital. And in this survey, what they did was they showed them a questionnaire with 22 questions and photographs of both male and female physicians in various forms of attire. They asked them to rate them across a number of domains, including whether they appeared trustworthy, knowledgeable, caring, approachable, and comfortable. There's actually a lot of interesting findings in this study, which was published in BMJ Open. But I'll draw you to this conclusion, which was the preference for the white coat. When you look across both men and women in the hospital setting, the white coat was strongly preferred by patients. And in fact, this held up across all settings except for surgeons. Draw your own conclusions. In fact, more than half, 53%, reported physician attire was important to them during care. Over a third agreed that it influenced their satisfaction with their care. And formal attire with a white coat was most highly rated, but surgeons apparently look good in scrubs. I don't think the researchers, though, looked at whether or not patients and hospitalists were just excited to see them anywhere outside the OR, though.
All right, so we're going to go from fashion, which apparently we didn't read that study enough, to a company whose CEOs are really known for having no fashion. That, of course, is Apple. So Tim Cook developed stress cardiomyopathy with an EF of 30% after using his iPhone and realizes that it's failing to recognize his face for the 1,000th time in Whole Foods. Don't you hate that? He held up the whole line, and it was so embarrassing. And then in this study, he develops AFib. So what do you recommend? Are you going to rate control him? The more beta blockers for Tim Cook, the better. How many are going to rate control? We got some takers. How about rhythm control? Bring back the Sotalol, anyone? No? How about ablation? Technology is great.
Couple takers.
Couple takers.
Mostly shy people.
I know. It's after lunch. It's hard. How about I have no idea? Every cardiologist I talk to recommends something different. I'm with you. I'm with you. So what do we know about AFib and CHF? Well, we know that AFib is bad. AFib and CHF is worse. And in patients with advanced CHF, it's really common, so that by the time they reach New York Heart Association Class 4, about 50% of patients will have AFib. And when you combine CHF and AFib, you get remodeling, a switch from paroxysmal to persistent AFib, decreased LV filling, decreased contractility, and decreased cardiac output, all suboptimal. This is truly a case where bad AFib is never good until worse happens, which is CHF and AFib together. So we're going to talk about the Castle AF study. Before I do that, if you remember, we've heard all kinds of things about what we should do with AFib over the years. We should rhythm control. Oh, wait, that kills people. We should rate control. Oh, wait. So now we're recircling back to what should we really do with AFib. This asks the question, in patients with AFib and heart failure, what is better, catheter ablation or medical therapy? It is important to know that this study was sponsored by Abbott. It is an unblinded, multi-center, randomized controlled trial of just under 400 patients over 33 sites. Patients had to have an EF of less than 35% and symptomatic AFib and CHF. They also already had to have an AICD in place. Half of them were randomized to ablation and half to medical management, which is rate or rhythm control. The primary endpoints were all-cause mortality or hospitalization for CHF. The exclusion criteria were actually pretty modest, so having had a prior ablation, being on the transplant list, or having a planned intervention. And what you can see is that ablation really was the winner in terms of hospitalization for cardiac etiologies, mortality. The only place that it was equivocal was for all-cause hospitalization or prevention of stroke. And if you look at the numbers needed to treat, it's 8 to 10, really impressive. So based on this, we should be asking ourselves, if given the choice between ablation or medical management, we should probably be asking about ablation. However, many of you did not raise your hands for that, and it is fair to ask, well, what is everyone doing right now? And the reason why is that there's a lot of discussion that the Castle AF trial has led to. Enrollment was really slow. It took 8 years to enroll 400 patients. I feel like I could enroll 400 patients that meet this criteria in my hospital in a year alone. The trial was actually stopped early due to slow recruitment and lower than expected primary outcomes. About 2 times as many patients in the ablation group were lost to follow-up, so some events may have been missed. More minor points are that the mortality took 3 years to see, though the hospitalizations, to be fair, dropped almost immediately. It's also important to note that at 60 months, just over 60 patients in the ablation group were still in sinus. That is better than the 20% in the control group, but nowhere near 100. To follow this up, analysts did a meta-analysis. They looked through 25,000 studies, bless them. They got down to just under 100 and picked 6. These 6 were randomized controlled trial looking at this question and had at least 6 months of follow-up. They included not only mortality and hospitalizations, but some quality of life measures, how well people's EF improved, and then compare that to who had problems with the ablation. This is some of the results. So in all-cause mortality, the recovery of EF, and heart failure hospitalizations, ablation really seems to be the winner. It's a little bit hard to tell, though, but Castle AF was by far the largest study at just under 400 patients. The next biggest study had 101 patients, and all the remaining 4 studies had 35 patients or fewer, so they were tiny. And so there's a lot of caveats to this. One is that Castle AF clearly drives the positive results in this meta-analysis. 2 is that it's really hard to differentiate. Some of the studies did not take out people whose tachycardia had caused their CHF versus those that have CHF and then developed AFib. And I think those groups are probably very different. There was some other concern about selection biases. The follow-up in some of these studies was very limited. And it was not blinded because, let's be fair, it is really hard to placebo an ablation. Stay tuned. Like in the renal disease, there's a bunch of studies coming. There's RAFT-AF, CATCH-AF, and then AFARC-LVF was supposed to have enrolled in December, and no one has heard from them since 2017. The AMICA did enroll and completed in the summer of 2017, and the results are pending. We're all eagerly awaiting these. So the takeaways are, don't pick AFARC as the acronym for your trial. That went really bad. It was a bad acronym. The meta and meta-analysis is less compelling when one trial drives the findings. That said, it may be time to be more friendly with your EP colleagues, because I do think that catheter ablations in patients with CHF and AFib are going to continue to be a question. And who knows, now your iWatch can diagnose your AFib. Maybe one day we'll ablate it too. To go along with cardiology, we're going to do the COAP trial, because really, can you be in the New Journal or cardiology trial without an acronym? This was another industry-sponsored trial looking at the MitroClip. It was an unblinded and randomized controlled trial of 78 sites, all in the US and Canada. It was just over 614 patients who all had an EF of 20 to 50%, and who all had secondary moderate to severe or severe mitral regurgitation. So this means that their mitral regurgitation was driven exclusively by their left-sided heart disease. This is a group of patients whose outcomes are actually quite poor now, and the only thing that we've offered them before was resynchronization or medical therapy. We were taught to leave the mitral regurgitation alone. Criteria were that patients had to be maximally medically managed before they entered the study and have undergone resynchronization if they were eligible and still have symptoms. And the outcomes were CHF emissions over 2 years. And what you can see is that blue is better, so lower is better in this study. And the people that got mitral clipped did much better. They had lower hospitalizations and lived longer. Cardiologists were very excited about this. This got presented at the ACC meeting last year, almost exactly a year ago, and they thought this was a really big deal. There's some caveats, though, is that patients really needed to have failed medical therapy. Patients in the study also had their CHF medications very optimized. They were followed by 3 cardiologists. I have never had 3 cardiologists follow my patients at the same time. A similar trial called MITRA-FR, I will say the Americans and the Canadians, they got the better acronym, was looking at MitraClip and did not demonstrate differences in outcomes. There's a couple reasons that people think this may have happened. One is that patients in the French trial were not as medically optimized, and so the control group and the intervention group, when followed by 500 cardiologists, may have both improved. And two is that actually in the American and US trial, this one, there was often more than one mitral clip placed, and so there's some thought that the mitral regurgitation was better managed in those patients. I think this does merit, however, thinking about calling cardiology for our patients who have secondary advanced MR.
All right, Carrie, you mentioned that the New England Journal, it's hard to publish without an acronym. It also seems now that it's hard to publish in the New England Journal without industry sponsorship. I think it's worth us mentioning that
Yes.
the MitraClip study, CASTLE-AF, and edoxaban all were sponsored by industry. So let's move from CASTLE-AF to a couple CEOs that are crazy AF. In a desperate attempt to escape the depressing US news, Elon Musk and Richard Branson are both working on space exploration. They get in a fistfight. Elon punches Richard, resulting in a little subdural. Neurosurgery is consulted, and they say, admit to medicine. You note, of course, the ED has started oxygen. You should, A, continue oxygen. Don't people pay for oxygen therapy? B, wean the oxygen. Any takers? C,
Get some.
seriously, wean the oxygen, take it again, wean it again. Or just give up, admit to medicine on oxygen. Well, according to the prestigious Gomer blog, a study was published this year that showed oxygen is less functional when the nasal cannula is worn as a headband. Who knew?
Who knew?
Who knew? Who knew?
Hi.
Hey, do you know what I love about oxygen nasal cannulas? It's like my own little elf on a shelf, because no matter what it says in the computer in the morning, I come into every patient's room and I get to search for it. Is it in their armpit? Behind their head? Where is that oxygen? And then I'm like, oh, they don't need it. So I take it off, roll it up. I could take it out of the room. I come back in the afternoon, stop in, hey, how's it going? Oh, there it is, it's back. But you know, actually the people putting it on their forehead might be doing the right thing, because there's been a number of studies over the last couple years, in fact, some featured at prior updates, that have found that liberal oxygen use, given oxygen when it is not required for hypoxia, may actually be associated with mortality. And this year, The Lancet published a systematic review and meta-analysis of all of these studies called the IOTA trial. They looked at randomized controlled trials comparing liberal and conservative oxygen therapy in acutely ill adults. They included 25 randomized controlled trials, and they looked across 16,000 patients who had either sepsis, critical illness, stroke, trauma, MI, or cardiac arrest, or patients who had to undergo emergency surgery. And what they found was, if you look at that top line, that blue one, that is conservative oxygen therapy. There seems to be a mortality signal. Now, this isn't like, you need a laser pointer to sort of get between them here. This isn't like the MitraClip study. But it's pretty amazing that they were able to find that there was a difference. And to strengthen their results, they found that there may actually be a dose response. So for every incremental increase in SpO2, there was, it looks like, an increase in mortality. And this was particularly found in patients who had MI or acute stroke. This led the BMJ to publish some new recommendations. And they say now, based on strong evidence, that for acutely ill adult medical patients, with very few exceptions, we should stop oxygen therapy no higher than 96% saturation. For patients with acute MI or stroke, they recommend, based on strong evidence, that we do not start oxygen therapy at or above 93% saturation. And they said there's weaker evidence to suggest we shouldn't start between 90 to 92%. Just 2 weeks ago, I had a patient who was having a pretty big active end STEMI, and I came in, and he was satting 94%, and he was on 2 liters oxygen nasal cannula, and we took it out of his nose and talked to the nurse about it. But I know this is not going to be easy, because we all know the oxygen ferry comes in the middle of the night, without orders, nobody is sure where it came from, just pops it on every single patient. But our job is going to be to come in the morning and start taking it off and explaining to others why we're doing that, because we might actually be harming our patients by giving them too much oxygen.
You know, we tried to make our slides really narrow down, but we wondered after all of this talking, couldn't we be more concise? And other people wondered this too. Is it time to start using the emoji in biomedical literature? People have asked. There is some thought that maybe we'll go from looking really smart to kind of drooling. And so we thought we'd let you see what you think. I'm going to summarize a few of Chris's studies. This one is in C. diff, thumbs up for vancomycin, thumbs down for Flagyl. And it is time to stop our love affair with oxygen, especially for people with MI and stroke. So, I don't know, we'll see. If you're not convinced, we'll try it for one more trial. The next trial is the balanced crystalloids versus saline in non-critically ill patients, called SALT-ED or SALTED. This is a single-center, pragmatic crossover study, which basically means that if you entered the Vanderbilt ED during these 16 months, 1 month you got balanced crystalloids, which is essentially LR for all the patients in the study, and the next month you got saline. And they looked to see which patients did better. They actually did not control what you got once you got admitted, but only in the emergency room. You had to have gotten over a certain amount of fluid to be entered into this study, but it was a huge study of over 13,000 patients over this time. While they did not find decreases between the two groups in 28-day hospital-free stays or mortality, they did find that major adverse kidney effects were lower in the group that got the LR, and it was significant. The number needed to treat was 111, which isn't crazy high, but if you think about all the fluid we give patients in the emergency room, isn't terrible either, and it's not like LR is super expensive. These investigators were actually not only able to get one publication in the New England Journal, but they were so smart that they did a second trial in critically ill patients called the SMART trial and showed the same thing. This was actually looking at patients and their fluid in the ICUs, both in the surgery ICUs and in the medical ICUs at Vanderbilt, and those patients did better too. And in this case, not only were there decreased kidney outcomes, but there was also a trend towards decreased mortality. So it looks like LR may be our fluid of choice. Moving from LR, we're going to talk about albumin. This is the human albumin for the treatment of ascites in patients with hepatic cirrhosis. Wow. Answer. Now, I want the answer of did it take longer to do the trial or come up with the acronym answer? I have capitalized how they got that because it took me a long time to figure it out. This is a multi-center open label Italian study with 440 patients, half of whom got medical treatment for their cirrhosis. They all had to have uncomplicated ascites, and the other half got medical treatment plus albumin. This was albumin 2 times a week for 2 weeks, and then once weekly for 18 months. There was a ton of exclusion criteria. So you had to have uncomplicated persistent ascites, but not refractory. You could not have had a TIPS, have HCC, be actively drinking, have gotten albumin for a month, be on the liver transplant list, have other organ failure. Oh my goodness. The outcomes are 18-month mortality. And what they found was that people that got albumin did better. The strengths of the study that it's the largest study looking at this up to this point. There had been a smaller pilot study that had shown the same positive outcome. It was also a very mixed population of patients in terms of the etiology of their liver disease, so that was a positive. The weaknesses, as you can guess, is that there was no placebo group. They did not compare this to TIPS, and we know that people that get TIPS have some mortality benefit as well. They also, as you can imagine, screened a ton of patients, and only about a third of those met their inclusion criteria because of all those exclusion criteria. The other problem is that many of our hospitals have had albumin shortages, and albumin is expensive. And I can barely get to the grocery store once a week, and so getting patients to come in once a week for albumin is a big ask. My takeaway is I think this is a compelling study, but I think we probably need more information before we all prescribe albumin weekly for our patients who would meet this study criteria.
Great. Okay, so our next case, we've got Howard Schultz, who's the CEO of Starbucks, who after mastering the art of selling coffee that millions of people now realize maybe doesn't taste very good, decides to run for president. To get ready for this, he decides to have a little cosmetic touch-up done. What would you recommend he do with his ACE inhibitor on the morning of surgery? Should he A, take a double dose? If little is good, more must be better. B, take his regular dose. Come on, there's got to be more of you. C, hold the morning of surgery and restart the day after surgery. A lot of you, good. D, don't ACE inhibitors cause cancer? This prospective randomized study at a single academic medical center was published in the Journal of Hospital Medicine this year. It looked at preoperative ACE inhibitors. They included 291 adults who had gone to a pre-op clinic and had been taking an ACE inhibitor for at least 6 weeks before being scheduled for a non-cardiac, non-vascular surgery. These patients had to have a systolic blood pressure between 90 and 160, had to have an LVEF greater than 40%, and could not be on dialysis. They randomized these patients to either omit their ACE inhibitor before surgery or to continue it. And then they had 120 patients who underwent the planned surgery and adhered to admit their ACE inhibitor, and 127 who underwent the planned surgery and adhered to continue their ACE inhibitor. The primary outcome was intraoperative hypotension, any systolic blood pressure recording less than 80. And what they found was that those patients who continued on their ACE inhibitors had significantly more intraoperative hypotension compared to those who held their ACE inhibitors for surgery. The authors calculated that there was a number needed to harm of 7.5, which is pretty significant. They also followed them out after surgery, and those patients who held their ACE inhibitor had fewer postoperative hypotension events, but they also, as you can imagine, had more postoperative hypertension events. The takeaway, these authors concluded that transient preoperative interruption of ACE inhibitor therapy is associated with a decreased risk of intraoperative hypotension, and so it seems like a pretty simple thing to do. I've definitely started to implement this on my teams. Patients coming in on ACE inhibitors before they go to surgery, we just go ahead and hold it if they fit that criteria. While we're talking about ACE inhibitors or ARBs, let's quickly touch on another study that was published in JAMA Internal Medicine this year. This was a large retrospective cohort study that looked at more than 40,000 patients in a public health database in Alberta, Canada. And they looked at patients who had been discharged from the hospital with acute kidney injury, and they saw whether or not they were started on an ACE inhibitor or an ARB within 6 months after discharge. They followed them out for at least 2 years. And what they found was pretty interesting. Those patients who got started on an ACE or an ARB within 6 months of being discharged from the hospital for acute kidney injury had a lower all-cause mortality compared to those who did not. Now, they also found that those patients started on ACE and ARB did have more hospitalization for a renal cause. So they ended up being hospitalized more, but their mortality was lower. So, Carrie, if to you, death is worse than coming back to this hospital, you might want to consider starting an ACE inhibitor.
So I heard from my British friends that ACEs cause cancer.
What? That can't be right, right? I don't know what they do there in the UK, but that's not what we do here. Let's look into it. So in BMJ, there was a large cohort study, nearly 1 million patients who'd been newly treated with antihypertensive drugs from 1995 to 2015. They were identified and followed out until December 2016. And they were looking for whether or not these patients developed lung cancer. There was biological evidence to suggest this could be the case, because ACE inhibitors may increase the risk of lung cancer through accumulation of bradykinin or substance P in the lung. Remarkably, the results showed that use of ACE inhibitors were associated with a 14% increased risk of lung cancer in this group. And this association became evident after 5 years, and it increased with longer duration of use, especially for those who had been on ACE inhibitors for more than 10 years. So it seems that we should consider holding ACE inhibitors for surgery in patients with pre-op systolic blood pressures between 90 and 160, so to decrease intraoperative and postoperative hypotension. We should consider starting, or at least recommending to our primary care colleagues at time of discharge, an ACE inhibitor and ARB following hospitalization for acute kidney injury. Unless, of course, it turns out that that causes lung cancer. So we need to stay aware of that evidence as it comes out as well.
You know, when I look through all these studies, I realize it's really hard to get published. And I wonder if that drives people to do crazy things. And if you aren't sure of the answer, I have this study for you. This is called Everything is Awesome, Don't Forget the Lego. The problem statement is that I'm med peds and kids eat the weirdest stuff. So what happens if adults do too? The aim was to get researchers to eat a Lego figurine head, which is pictured up on the corner, for free. and then determine the typical transit time until the Lego was seen again. And we have to ask ourselves, is everything awesome when you do this? So to get at this answer, it's very important. They looked at the stool hardness in transit, or the SHAT time, and they compared that to the found and retrieved, or the FART time. I would like you to know that there were 6 people in this study, but there are only 5 dots. And the reason that is because participant B looked through 13 stools over 2 weeks and never found his Lego. It was very sad.
Sorry.
And so their findings were that objects pass through adults in 1 to 3 days. Legos in stool are hard to find. But the takeaway is that everything can be awesome for you if you eat the Lego, as long as you let it go. I cannot say that Legos were not harmed in this study. And sometimes science requires amazing personal sacrifice. Do you remember Barry Marshall, who drank H. pylori? At least he got the Nobel Prize.
There's a YouTube video, which Carrie I watched, with these brave researchers, showing them swallowing their Lego heads, drinking some water, and then describing about their search.
I just kept looking, and it wasn't there.
All right, anybody feeling nauseated? Need some Zofran? Our colleagues in the emergency department performed a really interesting randomized, blinded, placebo-controlled trial where they took patients with nausea or vomiting. They had 122 adult ED patients, and they randomized them to either sniff an alcohol swab and get 4 milligrams of oral ondansetron, sniff an alcohol swab and take an oral placebo, or sniff a placebo saline swab and get 4 milligrams of oral ondansetron. What do you think happened? Well, actually, sniffing the isopropyl alcohol outperformed the ondansetron. These patients had a quicker and better response for their nausea and vomiting. And when they looked at patients who stayed in the emergency department longer, so they measured their length of stay in minutes. So here was 240 minutes length of stay. Inhaling isopropyl alcohol still performed better than oral ondansetron, but the combo seemed to outperform both. It's a small study, but we feature it because the New England Journal Journal Watch actually said it's uncommon for us to assign a rating of practice changing to a small single center study, but these results are truly remarkable and they're consistent with prior research. So they recommend changing practice. They say for patients not obviously requiring IV therapy, we should treat nausea and with repeated inhalations from an isopropyl alcohol swab instead of administering any other drug. All right, Carrie, what did we learn today?
All right, so our takeaways are that coffee equals a long life. Yay! Though being the CEO of a large chain that serves coffee may not qualify you to run as president of the United States. Consider LR for patients being admitted to the ICU or the medical floor, especially if they have or are at risk for acute kidney injury. And patients do care what you wear, and apparently do not know or care if white coats spread germs.
We learned that buprenorphine may have a number needed to treat of 50 to save a life for opioid use disorder, and perhaps even a number needed to treat of 2 for keeping patients in recovery. So it seems like this is time it becomes standard of care. Those who want to learn more, our friends and colleagues from Zuckerberg San Francisco General, Hannah Snyder, Marlene Martin, and others, will be leading a workshop tomorrow morning about how hospitalists can address this. And my friend and colleague Rich Botner from Del Med will be talking about our B team, our buprenorphine team, which is the hospice-led team, during the Best of Innovations abstract at 3:30 today. Oral antibiotics may be non-inferior to 6 weeks of IV antibiotic courses for left-sided infective endocarditis and for bone and joint infections. But we're going to need close ID consultation and close outpatient management to do that safely. And no more Flagyl for C. diff. Everybody say it with me. No more Flagyl for C. diff. Amen.
Cardiology continues to pick acronyms that have nothing to do with the thing being studied, though CASTLE may refer to the size of the house that EP doctors will be able to afford.
Castle AF.
Consider consulting cardiology, EP, CT surgery, any of those friends for patients with CHF and symptomatic AFib and or moderate to severe secondary mitral valve regurgitation. And in cardiology, everything we do now will probably be completely wrong in 10 to 20 years.
Stay tuned. We should hold those ACE inhibitors for surgery, but consider starting them after AKI, unless they cause cancer.
DOACs are being studied in more and more populations, including malignancy and end-stage renal disease. Apixaban 5 milligrams, unless the patient weighs less than 60 kilograms or is over 80, seems to be the winner in the DOAC category, at least for this year. There are some caveats. There's a debate about using this in patients whose BMI is 40 or above, and as Chris mentioned, it is BID versus daily dosing. Look for more studies regarding management of AFib in patients with CHF and DOACs in patients with end-stage renal disease, because they're coming.
Nothing is safe. Even those little oxygen nasal cannulas. Extra oxygen likely hurts patients, especially those with MI or acute stroke. So just don't write wean oxygen is tolerated. We have to actually do it. Aromatherapy may be better than Zofran, but aromatherapy is a really grandiose term for this. Oh my gosh, Carrie, we did it. We did it.
20 studies, 1 hour. We did it.
All right, I'm going to go get more coffee. See y'all later. We crushed it. Thank you for doing that with me.
Same.